We will perform passive range of motion goniometric measurement for shoulder flexion. The first thing that you should do is take the body part through a couple of reps of passive range of motion just to make sure the tissue is extensible and to get a good sense of where their end range falls. Once you get a good sense of where the end range falls, now would be a good time to take your goniometer and preset it to what you just saw. So in this case, she saw the shoulder go to about that distance, so she's presetting it and she'll put the goniometer down. Now she'll take the limb back through her range of motion. She'll line up her landmarks using palpation skills. First, she'll find her axis, which is over the lateral aspect of the acromion. And keeping your finger on that acromion as you flex up is helpful to maintaining that axis. She will palpate the lateral epicondyle of the humerus because the moving arm will fall along the shaft of the humerus towards the lateral epicondyle, and the stationary arm will follow along the lateral thorax in the direction of the greater trochanter, or staying parallel to the table. Watch for excessive lumbar lordosis in this case. Once passive range of motion is complete, the goniometer is placed in the landmark positions. Once the clinician has achieved the measurement, she will pinch it to make sure that the goniometer does not move. She returns the patient's arm back to neutral and then takes the measurement. And we can see what that measurement is. Now we move to shoulder extension. For this measurement, we will place the patient prone. Our landmarks stay exactly the same as for shoulder flexion, the acromion, the lateral epicondyle, and the flank of the thorax, or parallel to the table. Passive range of motion is performed to detect the limitation. Goniometer is preset, and then the measurement can be performed. Notice that the clinician holds the limb, supports it adequately, and maintains some elbow flexion so that we don't get a passive insufficiency of the biceps brachii. Once the measurement is complete, the arm is placed back to a comfortable resting position and the goniometer can be read. We will now perform passive range of motion goniometry measurement of shoulder complex abduction. The patient is supine. Several reps of abduction are performed to make sure that the tissue is extensible and we determine the end range. The pillow is placed out of the way. All restrictive material, sheets, clothing, and pillow are removed so that full range can be achieved. Clinician will then palpate for the bony landmarks to line up the goniometer. The axis will be the anterior aspect of the acromion, maintaining that finger as you move all the way through abduction because that axis will shift. So maintaining that finger is very helpful when we get to our final end position. Our stationary arm will run parallel to the sternum, and our moving arm will run along the midshaft of the humerus towards the medial epicondyle. The patient's arm is fully supported, making sure that the extremity remains in a frontal plane. Landmarks are palpated, measurement is taken, and the arm is placed back into a resting position. The goniometer is then read. This is the performance of passive range of motion internal and external rotation of the glenohumeral joint. The patient is supine. The extremity is placed into 90 degrees of shoulder abduction. And it is very important to maintain the frontal plane of the abduction. If we look at this patient from this angle, we can see that the patient is moving into slight horizontal abduction of the humerus. This can be remedied by placing a towel roll under the distal end of the humerus, making sure that the towel roll isn't too thick, which would create a horizontal adduction moment. So we try to achieve as much frontal plane abduction as possible. The elbow is flexed to 90 degrees and the arm begins in neutral rotation. Our landmarks for the measurement will be our axis is placed at the olecranon process of the ulna bone. The moving arm is along the shaft of the ulna bone towards the ulna styloid. And the stationary arm can either be parallel to the table or perpendicular to the floor, lining up with something vertical in the room to make sure that you maintain a vertical alignment. The measurement can either be for external rotation or internal rotation. The setup is exactly the same. So for external rotation, the clinician will preset the goniometer based on what she saw on her passive motion. Remember, we do not go past tissue resistance. In this case, the clinician decides to use a vertical alignment, so she makes sure that she stays perpendicular to the floor but aligned vertically with something in the room, and then the measurement can be taken. For internal rotation, the same process is completed. Care needs to be taken, however, when we internally rotate, that we don't catch the glenohumeral joint, if you can remove your hand, causing scapular anterior tipping. Notice that when the shoulder is thrown into internal rotation excessively, the scapula begins to anteriorly tilt. That gives us a false reading. We must make sure that the scapula stays neutral, is not allowed to move if we're looking at glenohumeral motion, and the measurement can then be taken more accurately. In this case, the clinician will use a stationary arm parallel to the floor or table just to show the variations in our technique. The arm is then placed back into a neutral resting position and the goniometer can now be read. This measurement will be for horizontal shoulder AB or adduction. Some techniques can be performed in a supine position. However, we feel that the table often is in the way, so in this case we will choose a seated position. The patient is seated with the shoulder flexed to 90 degrees. Elbow can be extended or flexed. It does not alter the motion. The axis of this measurement will be the superior aspect of the acromion. The moving arm will be along the shaft of the humerus towards the lateral epicondyle, and the stationary arm can be either perpendicular to the moving arm following a frontal plane, or can be aligned in a sagittal plane perpendicular to the frontal plane. If you're in a facility with a tile floor, the lines in the floor serve as a nice guideline to making sure that we are in the sagittal plane.
If you line the chair up right.
The starting position here will be 90 degrees flexion. And,
So the other option, because I think the text has starting up from here, but we like
true.
Starting point there, right?
So we're just 90 degrees flexion. So from a neutral position, we're going to flex 90 degrees. And now the measurement can be taken. So for passive range of motion abduction, the limb is pulled into horizontal abduction, allowing the scapula to move, making sure that the trunk does not rotate. And then the goniometer is placed.
So let's go perpendicular to her frontal plane.
There we go, and then the measurement is taken. For horizontal adduction, same landmarks. Making sure that the trunk is not rotating, the patient is sitting upright, the arm is well supported.
I'm going to do a parallel or to the frontal plane for demonstration.
Okay, so the stationary arm in this case will be along the frontal plane, bisecting both acromion,
Does that look good?
and the measurement is taken. Arm is placed back to neutral position, and the goniometer is read.